friends. My name is Emily, and I am the community manager here on 2 Diabetes, working with Diabetes Hands Foundation, and it is time for another Master Chat. And I want to tell you a bit about Master Chats before we get started. This is an annual series that's a collaboration between 2 Diabetes and Teachers College Columbia University's Master of Science in Diabetes Education and Management program. It is a mouthful. So this is our 4th year of this collaboration. And basically the intent of the collaboration is to create some back and forth between students in this program and members of 2 Diabetes. So the program consists of students who are interested, people who are clinicians and aspiring clinicians who are currently interested in working in the diabetes field or potentially already working in the diabetes field. And so we as patients and patient representatives on 2 Diabetes are here to learn from students in this program and also to give them our feedback as patients, because these are folks who either already work with people who have diabetes or are going to. So it's great for us to tell them what we like, what we want, what kind of information is important to us. So welcome and thank you for being here, folks. Today's presentation is by Jonathan Peng, who is a cardiologist, and he will be talking with us about metformin and cardiology. Metformin and its effect on the cardiovascular system is our title. And Jonathan, thank you so much for being here with us today. The camera is now on you. Please start by telling us a bit about yourself.
Well, thank you for having me. I am a non-invasive cardiologist that practices in Northern California. I have an interest in preventive cardiology as well as patient education, and that's kind of why I was drawn to the program at Columbia, kind of focusing on patient education and aside from just the clinical aspects of treating people and helping them with their life and you know what diseases they may have, also helping them educate and empower themselves to live a better life. So yeah, so that's basically me. Aside from my non-invasive duties, I also do a lot of teaching in terms of diet and activity kind of issues in terms of the cardiovascular disease. And diabetes tends to be one of the major issues that we see in conjunction with cardiovascular disease. So if you guys have any questions at the end of the talk, feel free to ask me as well.
Absolutely. So why don't we just launch into your talk, Jonathan? I know that you have some slides to get going here, so I'll give you a moment to get that organized.
Okay, so I am sharing my screen.
No, you're not.
I lied. Okay.
There we go.
You guys see my slides okay?
Yes.
Okay.
I can. We'll get a confirmation in our chat room, but I can see your slide perfectly.
Okay, should I then begin?
Absolutely.
Okay, so just as a disclaimer, I'm talking from home in between seeing patients because I had a firewall issue at my work. So if my daughter runs in here, please excuse her. She just got out of school. So I have an interest in kind of cardiovascular disease and various things that are associated, and one of them is diabetes. And as physicians, you know, many of us prescribe metformin as the first-line oral drug in type 2 patients with type 2 diabetes. So I kind of wanted to clarify, you know, some patients ask me why metformin, why not something else like the newer agents? You know, is there something that gives it a benefit? And you know, as I was training through residency and also fellowship, data continue to come in showing the benefits of metformin and why it's kind of a tried and true medication for decades and why we still use it today. Just a few disclaimers and disclosures. I did have a research grant from Johnson & Johnson 2013. Our group published a paper on drugs and EKG changes, so that has nothing to do with this. I don't have a financial interest in metformin, and it's also a generic medication nowadays anyway. And also, my lawyer told me I should put up a disclaimer in terms of consulting your healthcare professional for any specific advice related to your specific conditions, and anything I say today should be run by your doctor before implementing it yourself. So just a quick background. So we know that cardiovascular disease seems to be driven by something called atherosclerosis or plaque deposit from lipids that come from our diet, and also endogenous lipids that are made by our liver. And it's a huge sequela of diabetes. In fact, we know that people who have diabetes actually can get accelerated atherosclerosis in not just the cardiovascular system, but also the arteries throughout. So that includes the eyes, the kidneys, the nerves of the feet, the nerves of the arms and hands, etc. In training, yes?
I have a quick question. Can
Okay.
you define sequela for our audience?
Sure. So sequela is, I guess a good way of saying sequela is like the complications of diabetes. So diabetes, we all know, is an issue with difficulty in metabolizing glucose, and part of that is, you know, people get high blood sugars and you know, various metabolic things that go along with it. So sequela would be something that is a consequence of diabetes. So things like heart disease and kidneys and eyes and nerves and things like that. Does that answer the question?
It sure does. Thank you.
Okay. We do know that cardiovascular disease is actually the leading cause of death in terms of looking at death certificates in the hospital in patients who do have diabetes. And I'll show a little data in a bit of where we get that. And as a side, metformin, as I spoke about earlier, is one of the most fundamental therapies in type 2 diabetes. And there's a huge armamentarium of oral agents that we're using, but metformin seems to be the one that we really go to. And kind of, you know, we'll talk about a little bit about why, especially why in people who have cardiovascular disease. So this is kind of just a bar graph of that was released a few years ago. Basically, it took people who had diabetes and who had a death certificate from the hospital, or you know, if it was a coroner's case or whatever, and on the death certificate they analyzed what was the leading cause of death. And as you can see, IHD, or ischemic heart disease, and that just means people who had coronary artery disease or blockages in their coronary arteries tend to be the highest reason for mortality. The second one would be other cardiovascular events. So that can be a stroke, that can be heart failure, that can be rhythm events, you know, abnormal rhythms, things like that. Interestingly enough, the next one is just diabetes, and I didn't know what that meant. You know, did people just die from diabetes? I think basically that was saying that on the death certificate, no one really specified, aside from the fact that the person had diabetes. So I think that's kind of an outlier in terms of bad data. And then, of course, cancer is the other leading cause of death. So just as a side, you know, the top two leading causes of death per the CDC that are not accidents or drowning, things like that, are heart disease and cancer. And they continue to compete over the decade. Although I think cancer is kind of beating heart disease nowadays. This is just a coronary angiogram. The reason I wanted to show this, because it gives us kind of a visual of what diabetes actually does to our arteries. So we all know that diabetes causes changes in the blood vessels, and there are things called microvascular changes as well as macrovascular changes. Micro obviously means small, and macro means large, right? So micro arteries are really small arteries, and those things are in the eye, around the nerves, the kidneys. You know, the kidneys have small arteries that kind of feed upon itself. But macrovascular disease tends to be the ones that are more visualized and the ones that we can actually see with the naked eye a little better. And coronary disease tends to be one of those. On the left, you will see an angiogram of a patient who had diabetes. And on the right, you'll see someone who had a coronary angiogram without diabetes. As you can see, just by looking at it, the one on the left is very skinny, very thin vessels. The one on the right is a little more fat. And certainly there's curves in both patients, and there's branches and you know, there's lumpy and bumpiness in both patients. But as you can envision, someone who has very skinny blood vessels, the blood flow may not be as robust. And there may be issues not just with coronary plaque deposit, but also the blood vessel disease of the blood vessel wall itself. I'd like to also say that the blood vessel wall is a living organ. It's not just a pipe. A lot of people like to consider it like a pipe, but you know, unlike a pipe, it actually moves. It it metabolizes things that need nutrition. So it can get bigger and, sorry, my daughter said, okay, that's great. So it can get bigger and smaller based on, external factors. So with exercise, your arteries are supposed to get bigger because the chemicals tell it to. When you go to rest, the arteries sometimes can get smaller just because the blood flow is not as robust. So as you can see, someone with skinny vessels, they might not be able to dilate as much when they exercise, etc. So a little bit about metformin. Metformin is a pretty old medication. There are documented uses of it back in the 1890s. It comes from a chemical called the guanidines in French lilac, interestingly enough. It's termed a biguanide only because in the lab they can actually separate the guanidine into this compound called biguanide. It was used a lot in the early 1920s and the 1950s, and it wasn't called metformin at the time. It was another chemical structure called fenformin, and we actually stopped using it for two reasons. One was fenformin was very toxic to the kidney, and number two was recombinant insulin came out, and because recombinant insulin was at the time was so successful and a major breakthrough, metformin kind of fell by the wayside. But over time, or fenformin fell by the wayside, but over time, there was a physician scientist who actually could recreate fenformin in the form of metformin that was a little safer for the kidneys. So the way it works basically is it decreases the amount of glucose being produced by the liver. It also increases the uptake of glucose in the periphery, so such as the muscle and the other organs, allows it to be more sensitive. So it's very useful for people who have glucose sensitivity issues or insulin resistance. And also kind of decreases the absorption of glucose that you eat in your gut. So sometimes people may have side effects of GI upset because it does affect the intestines. The first study that showed that metformin was pretty useful in terms of increasing insulin sensitivity was done in 1957. So again, a very old drug. The safety profile is well known, and it's not one of those newer drugs that over time we may find issues with it that we have no idea about. So as you might imagine, metformin was first used as something that was known to decrease the amount of average blood sugar over time. But since then, we've been able to find out that it actually has other effects, and we call these pleiotropic effects. Pleiotropic meaning it's not what it's intended for, but the drug itself has other characteristics that are that we had no idea, we didn't plan for, and it just seems to be working out. So in 1999, this is a landmark trial in the United Kingdom. It followed a huge amount of patients in terms of what they're using for their diabetes therapy. So this included metformin, included people on glipizide and sulfonylureas, included people on insulin. And it found that, as we know now, again, back then it was pretty landmark, but as we know now, if you have good glycemic control, you will decrease microvascular disease and macrovascular disease. And part of this is coronary artery disease. So decrease in heart attack, huge. Interesting enough, even though people treated with sulfonylureas, insulin, and metformin all had better glycemic control and had improved rates of heart attack, so much less rates of heart attack, metformin had a much, much better profile of decreasing heart attack. So, at least a third, up to 40%. And with trials, it's nice to always do a follow-up. So this one's huge. It's 20-year follow-up showed that indeed it had continued to have this benefit in decreasing heart attack risk in people who took metformin versus the other medications. At that time, it was not proven that vascular protection was one of the pleiotropic effects of metformin, but now we know that it definitely is. So this is a really good summary paper about the various effects of metformin. I've taken the next slide or the next picture from it, kind of to help visualize the different things that metformin actually does. So in the top you see metformin as the starter agent, and it goes down into different enzymes. So AMPK is a kinase enzyme that regulates various metabolism and also cellular energy. The PI3K and the AKT also do part of cellular metabolism, as well as the PAI1. And those are kind of like really scientific details that we don't care about too much clinically. But as you go down the chart, you'll see that they actually have a endpoint that all adds to cardiovascular protective effect. So if we look at the AMP-PK, it's revved up and actually helps improve your lipid profile. So again, a lot of people think about statins and niacin and fish oil. They all help with your cholesterol and stuff like that. But metformin has been shown to be great as an adjunct to improving people's lipid profiles, and we use it in other things aside from diabetes, like polycystic ovarian syndrome. Those people tend to have some metabolic issues as well, so it tends to help with that. Oxidative stress is another kind of disease-modifying characteristic that it aids in, and oxidative stress seems to be prevalent in almost every disease that we have. So that increases the inflammation in your body. So metformin has some kind of anti-inflammatory component in terms of that. And then in terms of the energy balance and ischemia, when we talk about ischemia, we talk about there's a supply and demand issue with blood flow. So you're just not getting the amount of blood flow that your heart demands. And with metformin, it seems to improve the blood flow, and that's hence why it helps with the vascular effect. Myocardial infarct size is related to that in terms, if you have a infarction or a heart attack, how bad is that lack of blood flow during that time? Some people have a 70% blockage, some people have a 99% blockage. Metformin seems to decrease the amount of muscle that is affected in the setting of a heart attack. Now, we don't give metformin in the setting of a heart attack for people who've never used it. That hasn't been studied. Interestingly enough, it would be kind of cool to see if it actually does anything, but we do know that patients who have metformin on board as their home medications, if they do have a heart attack, we seem to find that the infarct size of the heart, or how much wall muscle is damaged, tends to be a little lower. And then the other thing is, as I talked about, diabetes doesn't discriminate against what blood vessels it affects all of them. So it doesn't discriminate, it participates. So metformin can actually help with peripheral circulation, actually help with the blood flow. So I think the common denominator in all of this is that aside from helping with glucose control, metformin protects the endothelium, and that is the fancy name for the wall of the blood vessel. So it helps the wall of the blood vessel continue its function as it's supposed to, and also helps blood flow a little better as a consequence. Its anti-inflammatory components is kind of secondary to all that as well. This is from a mouse study, and what we did was, well, not me, but what our community did was we took mice, and these are their aortas. So it looks like a candy cane. The long part goes into the rest of the body, the chest, the abdomen, the legs. And the arch part, where there's some blood vessels coming off of it, go to the head and the arms of the mouse. And what we did was we fed so the first box, LFD, is a low-fat diet. So these are 5 mice that had a low-fat diet, and we stained it for plaque. And then we took another set of mice and we gave them a high-fat diet. And as you can see, the staining is much more prevalent and kind of inundated with this stain. And then we gave the mice with the high-fat diet also metformin. And as you can see, there's a big difference in how improved the walls of the aorta look. There's much less cluster deposit. Now, as you also can observe, the high-fat diet plus metformin is not as good as the low-fat diet. So this kind of reinforces the fact that drugs are great; they do a lot for us, but they're not the end-all be-all, and lifestyle is actually extremely, extremely important. So despite the fact that metformin does provide some vascular protective effects, in conjunction with good lifestyle behavior and changes, it can actually lead to even better effects. So some people often ask, well, why don't we just give metformin to people without diabetes? How about people who've had a heart attack in the past, or people who, have chest pain or angina? Why don't we just give them metformin? We actually studied this, and this was a pretty good study. It came out in 2013, so fairly recent. And interestingly enough, it did not, the endpoint of this study was not, does it protect against heart attack? Are people taking metformin getting less heart attacks, less strokes, et cetera? It just measured how much plaque your carotid artery had. And, the people who take metformin, we know that it helps with the weight loss, and that was seen in both the people taking metformin and not taking metformin. But there was no change in plaque deposit in the coronary arteries. So is this study a end-all, be-all and saying metformin should not be given for people with coronary disease? No, it's not. It's just a study that suggests that it does not help improve plaque deposit in patients who do not have diabetes. There are other studies that are upcoming that will kind of investigate this a little further. It's always hard to do a study because you have to have a huge number of patients. And when you do have that, you have to follow them for a long period of time to see if there's actually a clinical benefit. So this is a good start, but we can do better. This is just my bibliography and in the sources that I used. And I guess I can entertain any questions you guys may have.
We have a bunch of questions for you. We have some great questions, Jonathan. So let me jump right into some of those. The first one, this is a question from David in our chat room, who says, does metformin produce its effects unilaterally, or does it act in synergy with other agents, for example, CoQ10? In other words, can the effects be enhanced by using it in combination with other things?
Well, that's a great question. I'll be honest, I don't know the answer to that. We don't have studies in showing synergistic effects of metformin and other medications. We do know that metformin plus insulin work synergistically sometimes because insulin does its job as insulin, but metformin will be an agent that improves cellular sensitivity to the insulin. So it kind of can be a 1-2 punch where the metformin will allow the cell to be more sensitive to insulin, then you give the insulin so it may work better. You bring up a great question about CoQ10. We do use CoQ10 for people taking statins. So CoQ10, as we know, helps the mitochondria with kind of replenishing itself and has some kind of anti-inflammatory component as well. So people who are afraid of side effects from statin use or have had side effects from statin use, if you use them in conjunction, it can blunt those side effects or improve them. So we do know that there is some kind of anti-inflammatory property as well as protective effect with CoQ10. Unfortunately, there are no studies that show it, and there's no animal models that show CoQ10 with metformin, but that's a good thought.
All right, so the next one is, you had mentioned during your talk that metformin, initially, there was a different formulation used that was a derivative of French lilac, and that was deleterious for the kidneys, that it had kidney danger involved, but that metformin, as it is currently formulated, is slightly different, and it has much less effect on the kidneys. We have a question in the chat room about how exactly does it affect the kidneys? And does it still have enough of effect to be any amount of concern to people who take it?
Yeah, so the difference between fenformin and metformin, and there are other derivatives as well that were not really used except in animal models and labs. The difference is just if you look at a chemical structure, there's all these kind of branches of what we call methyl groups and also other chemical groups that hang off of it. And whenever you change the structure, you change the function of any chemical or any drug. So fenformin had a huge amount of kidney damage. And it wasn't that it damaged the kidney itself. It was that it would lead to what's called lactic acidosis. So lactic acidosis is a dangerous amount of lactate being formed. And we know that, in a nutshell, lactate is part of a normal cellular metabolism byproduct. If you and I are weightlifting or running, like sprinting and not long distance, nothing aerobic, we produce lactic acid. That's what makes our muscles sore, right? But unfortunately, metformin and fenformins tended to shunt cellular respiration toward making lactate. So when you have a lot of lactic acid, that can be damaging, especially to the kidneys. So does metformin nowadays have that that issue? Yes, actually it does. For people who have existing kidney damage, it's not that you can't take metformin, but you have to be monitored and you have to be careful about it. So, if your healthcare provider should be monitoring, and you should be aware of it also. If you do happen to get like a test, like a CT scan that requires contrast, or even an angiogram for your coronary vessels that requires contrast, you should always hold your metformin for 40 hours prior and then restart 48 hours after. Or some people will even check your kidney function before restarting it. So although the safety profile is pretty good, and I personally rarely, I don't even remember the last time I saw an issue with people taking metformin have kidney trouble, and I have plenty of patients who've had contrast exposure as well as kidney issues. I don't remember the last time I saw lactic acidosis from metformin, but it can happen, and so we just have to be very vigilant of it.
Roughly how much metformin does one have to take to see an effect in terms of blood sugar regulation?
So I think that really varies between the individual. Usually starting dose of metformin is 500 milligrams. You can even do it once a day or even increase it to twice a day. The maximum dose is probably about 2,000 milligrams a day. So that's like 1,000 milligrams twice a day. I see, it really depends on the individual. So some people tolerate metformin very well. Some people's bodies accept it very well. And some people are very active on top of using metformin. So the people who, tend to have a very, a very active lifestyle as well as a very plant-based and very healthy diet, with metformin tend to do very well. So I think part of it is external. Part of it is how we live our life, but also part of it is how your body is going to respond to the drugs. We know that not everybody absorbs the same amount of drug. We also know that not everybody uses or utilizes the amount of drug they absorb to the same effect. So I usually, just from anecdotally, I usually see effect between 500 to 850 milligrams twice a day. You should start seeing an effect.
And Jane in the chat room is asking, are we seeing any differences in effect between regular metformin and extended release metformin?
Yeah, I personally don't have much experience with extended release metformin, only because I don't feel it. I feel the only advantage it offers is probably due to just the convenience of doing it once a day. I feel that it tends to be a little more expensive for people, so I tend to still prescribe the old run-of-the-mill twice-a-day metformin. Even sometimes that metformin can be taken once a day as well. I don't think there's particularly any huge benefit on a large population study on having extended release lower the A1C versus not, especially if you have patients who, they take their metformin twice a day at the same time. They don't forget doses. I think for people that have a very busy lifestyle and sometimes, if they're traveling, they run out of it or might forget it. I think in terms of convenience and making sure that it covers them, the entire 12 to 18-hour half-life, I think that might provide a benefit and in turn might indirectly affect outcomes. But I think by itself, if we are in an ideal setting where people are taking their metformin twice a day, I don't think it offers too much of a benefit over that.
All right. Well, our time is up, and I know that you have to get back to the hospital to see more patients. So yes. I appreciate your time very much today, Jonathan. Fantastic presentation, really edifying, and I wish you the best in your class.
Okay, well, thank you. Thank you for having me, and it was my pleasure to talk to you all.
Bye-bye.
Bye.